what I will be talking about just in brief in terms of my agenda. Why do we even want to talk about families? Why are we involving them? Talk a little bit about the role of families in family-based treatment, and then I'll talk finally also about parent guidance. So first, why do we involve families in this kind of treatment? Well, from my perspective, how can we not involve families? What I've put up here are just a few quotes from some of the families that I've worked with, and I'm certain that these will feel really familiar to all of you as well. So this is not my daughter. In the midst of the anorexia or in the midst of the eating disorder, it's almost as if she's somebody else. We've always been close, but now she can't even stand to be with us. None of us know what to do. I don't even know who we're talking to when we're with him. Is it my son or is it the anorexia? We're walking on eggshells around her. These are the kinds of phrases that we hear all the time, and I imagine that these are very familiar to you folks as well. So from my perspective, why not involve families? They're really at the forefront of this. We think of them as being at the front line of illness detection. Often they're the ones who are the closest to our patients, certainly in terms of living situation, but also in terms of having grown up with them. They're really the ones who are able to notice some of the first changes in kids with eating disorders. So they may be the ones who notice the change in mood, certainly the change in sociability. Some of the things that parents and family members will notice first and foremost is, the child is not hanging out with their friends as much as they used to, or rather than spending time after school at whatever activity, now they're really just coming home. Some of the things that they notice are changes in personality and certainly big changes in eating behavior. So, again, this is not unfamiliar to you guys, but one of the things that we see a lot of is that before this, there have been a lot of family meals or there's been a lot of snacking together, and all of a sudden there are big changes in that area so that kids are eating alone, perhaps they're preparing their own food, or they're making excuses about eating. One of the reasons that we think about family-based treatment in the treatment of eating disorders, and particularly adolescent eating disorders, is that parents are really the ones who we consider to have the greatest investment in their kids. I've put up here Yvonne Eisler, who's one of the really renowned family-based treatment physicians in the field of eating disorders. This comes from him, it's a quote directly. An eating disorder has a major impact on the family life. With time, food, eating, and their concomitant concerns begin to saturate the family fabric. Consequently, daily family routines, as well as coping and problem-solving behaviors are affected. So one of the reasons I put this up is that historically, many years ago, we had often thought about sort of a parentectomy, where when you're treating kids and adolescents with eating disorders, you would really want to separate them from the families, that you'd work on them separately from the parents rather than working on the family as a full system. Yvonne Eisler and his group at the Maudsley Hospital in London, as well as others, have really talked about the idea that you do need to include families in this. We certainly do see enmeshment, we certainly do see over-involvement, and we certainly do see a lot of parental criticism. But I think if we could all in this room try on for a moment the idea that our child or our sibling or somebody that we're very close to is really direly ill and behaving in a way that is really puzzling and confusing, and we feel as if we have no control over what to do, all of us might become a little crazed. All of us might become a little over-anxious, and certainly we may actually act in ways that we wouldn't otherwise. So the point of putting this up here is to suggest that sometimes some of the things that we see in families of kids with eating disorders is actually not necessarily preceding the illness, but rather a result of having a really hard illness going on in the family that really throws everybody off. And that's the frame for family-based treatment. How many people in the room are familiar with family-based treatment or FBT or the Maudsley method? Okay, so many, so that's great. I feel like I have allies in the room. So let me just share with you a little bit about it in brief. It's something that, again, many folks have described. It started at the Maudsley Hospital in London, so a lot of people refer to it as the Maudsley method. We now call it family-based treatment. The two people in the States who have written the most about this are Daniel LaGrange and Jim Locke, and they've published 2 manuals on this, both of which I've included here. But the other resource that I really do actually always recommend to families is their book, Locke and LaGrange's book, Help Your Teenager Beat an Eating Disorder. I think it's a really powerful resource for families, partly because it's really not blaming, and it really empowers the parents and gives them tools to work on. So I'm sorry that I haven't put that up here, but it's also by Locke and LaGrange. So the idea of family-based treatment is that it's a short-term, structured treatment that proceeds through 3 phases. The basic principles are that eating disorders are viewed as a developmental setback. They really throw both the kid and the full family off track. The parents must step in to interrupt the symptoms that the patient is considered not to be able to control. So rather than viewing the dietary restriction or the binging and purging as a choice, the family-based treatment model really sees this as maybe it was a choice when it first started, when the diet began or when the binge began, but at the point that folks are coming in for treatment, it's not a choice anymore. And at this point, the eating disorder itself has really taken on its own life, and it requires some sort of intervention to really get a hold of. And this frame takes the frame that parents are the ones that can do that. It proceeds through 3 phases. The first is really refeeding, and this is in the frame of anorexia nervosa, but certainly this is a treatment that has been manualized for bulimia as well as other types of eating disorders. And so in that, I think about it as parents refeeding, but really parents interrupting the eating disorder symptoms. The second is that once the weight is up and once the eating disorder symptoms have been interrupted, then the child is able to move to eating independently. And then finally, we take a return to normal development. Often, as you guys can imagine, for kids with eating disorders, they've been off track for 1, 2, 3, many more years sometimes. And it seems like particularly for kids with anorexia, for restrictive eating disorders, they've often become really off course in terms of their development and their social development. And so when they get back to a healthy place in terms of their behaviors, in terms of their physical symptoms, it can often take a fair amount of work to help them get back on track in terms of what else they've missed during the course of their illness. So I thought I would go through the treatment in brief. The first phase, as I said, is the parents refeeding the child. I want to step back for a moment and remind everybody that this is a treatment that we think about as an outpatient treatment. So it's typically seen as a 20-session outpatient family-based treatment. It's done really for kids who are medically stable. So this is in lieu of a higher level of care, but often a higher level of care is needed even before kids are ready to graduate to family-based treatment. So this is really for kids who are greater than 75% of their ideal body weight. One of the most important pieces here is the first point, which is that the therapist really absolves the parents of blame. For anybody in the room who works with parents, you're all really familiar with the fact that parents carry an enormous amount of guilt and responsibility, whether they have a child with an eating disorder or not. You know, like, did I brush my 1-year-old's teeth? No, I didn't. I feel terrible about it. Is he going to get cavities next year? I don't know. So who knows? I think that we all carry whatever it is. And one of the first steps in family-based treatment is really trying to actually let the parents know that we see them as a teammate, that we really see them as a key resource for working on recovery. They're not to blame. In fact, if we knew exactly what caused eating disorders, we would all be in a better position, but we don't. And so this kind of a treatment takes an agnostic approach to etiology. It really says, you know, here we are. It focuses on the present and trying to help everybody come together as a resource. Parents and patients are supposed to eat all meals together. You can imagine, especially for kids and adolescents, this is a big challenge, particularly because most of our kids go to school. What I have had happen, and what I highly recommend, especially in the beginning of treatment, is that if parents do not see a meal happen, it didn't happen. It's not because the child isn't trustworthy, it's because the eating disorder makes them do things that they wouldn't otherwise do. And so what parents will often do is actually go into the schools or take the kid out, have lunch in the parking lot, have lunch elsewhere. And this is where I look at DOT. This is where we look at nurses. Nurses in the schools are actually often a really critical resource. For some families, as you can imagine, it's actually just not a possibility that they would be able to take time off from work and go to school. And so we do really partner with schools, and that can include the nurses, it can include other folks at schools, to really make sure that they're on board with being able to provide supervision around eating. This can be a real motivating factor, as you can imagine, especially for the young teens who already feel a little bit different or a little bit ostracized, don't want to be having their meal with their parents, and certainly don't want to draw any kind of attention to themselves at school. So I really try and frame this as a short-term intervention. The idea is certainly not that mom or dad or nurse is going to be supervising their lunchtime meal and interrupting their day, but health comes first. And at the point when they're coming in for treatment, they need that level of supervision in order to ensure that they're able to make the adequate weight gains and really interrupt the eating disorder. Part of the way that we think about it is that when given the opportunity, usually the eating disorder will make them do things that they wouldn't otherwise do. The eating disorder would make them restrict. And what we try to do in this model is really create such a tight net that there's no room for the eating disorder. And in order to really create that tight of a net, it means full supervision around all meals. Finally, we work hard to separate the child from the eating disorder. And this means that when parents and everyone in the room are expressing criticism or expressing frustration, we try hard to really remind them that what they're really frustrated by, and the reason that all of us are frustrated in working together, is to fight the eating disorder rather than the child. And one of the strategies that Daniel LaGrange in particular uses is the idea of really thinking about the parents as like a rescuing agent, to remind families that actually the kid is in there, and it may just be that we don't see her that often or we don't see him that often. I had a family just 2 weeks ago whom I've worked with in a really intensive way because they're a traveling, visiting family. One of the siblings described something I thought so beautifully, and I certainly won't be able to recreate it, but what she said was that it felt like when everybody was together, that it felt like they were all kind of looking at, like it was as if they were looking at an alien, and she knew, and she described it using a visual of like a tissue box, that she knew, you know, inside the box was the tissue, but she couldn't see it. Inside this alien being was actually her brother, but she just couldn't see him all the time. And it was a really, to me, it felt like a really powerful way of describing that he really wasn't himself because of the anorexia. The second phase, once the child has been able to make adequate weight gains, and we usually think about this as being able to reach about 90% of ideal body weight, then we're ready to move into transitioning control over the eating back to the adolescent. For anybody who practices family-based treatment, you can probably attest to this and agree with me that actually figuring out when and how to transition to phase 2 is enormously challenging. You know, in many ways, kids feel like they're ready to do it and they want to go back to it, but actually when given back the control over eating, beginning to make more decisions over their eating, they often slip back. And so I think about moving between phase 1 and phase 2 as really a delicate dance that you kind of go back and forth, giving them more and more control, but really being able to see that they're continuing to make weight gains. In this, one of the ways that I often think about cognitive behavioral therapy, of which I think family-based treatment is an example, is that I do use the example, and I'm sure many of you have done this as well, but I think about, you know, a kid as like a car, and whatever kind of fancy car they want to think of, they've been trucking along, doing okay, and all of a sudden there's a breakdown. Maybe it was a slow breakdown, maybe it was sudden, whatever it was. Our first job is to patch up their tire and help them move on. And that's really phase 1 of family-based treatment. The second piece, once they're driving along, is to really say, okay, what did you run over, or what might you have missed in that window that you were really broken down or breaking down? And that really is in the service of helping them be able to continue to go forward, because it might be that they'd run over something similar again down the road. And that's sort of where we start to get in phase 2. And that's a big piece in phase 3. What I've put here at the bottom is that the patient may at this point begin to return to normal activities. That could be sports, it could be other kinds of activities, again, where they're now able to do a little bit more independently. The third phase is really the phase around returning to normal development. And at this point, as I've said, what therapists and what the families are going to want to be attending to is what might the kid have missed out on during that window of time that they were falling ill. It could be making relationships, and so maybe right now a big struggle could be alexithymia, could be trying to sort of reinvent what relationships might he or she have missed in that window, and how do we help them build those back up. What we see a lot of is social anxiety in many of these kids, particularly in those with, actually with both, with bulimia and with anorexia. And so trying to do work around helping people get back on track in terms of building relationships can also be an important piece here. Okay, so how do we actually do it? This is the question I get from parents, and especially usually when we're first introducing FBT. So one of the things that we offer at MGH, and one of the things that I sometimes think about, is actually parent guidance. So doing family-based treatment is awesome, and it's also limited. So there's a lot of research suggesting that, it's the first-line treatment for adolescent eating disorders, and I think that's true, and I think it's wonderful, and I really try to offer it as a first-line approach. But I will say that at the end of the day, I have found it to be a bit sobering to see that in the literature, even by the folks who do this treatment and really are the proponents of this treatment, the recovery rates are closer to 40%. And the reason that I profess feeling sad about it is because I guess kind of, following both from Karen's talk and also from her videos, I think that our expectation as clinicians and as folks working with these patients is that they should be able to recover. I do think that these are often chronic illnesses, but my expectation when I'm going in to work with these patients is that they're going to get better, and I'm going to hang in there with them as they proceed through it. I don't know if Karen's here right now, but as we heard from her, these can be really chronic and they can be long-term illnesses, but most people do come out on the other side. And so having said that, we often have to use a lot of different kinds of creative strategies. One of the ones that we think about using as well is parent guidance, particularly maybe for parents of older teens, of kids who are in college where family-based treatment may be impractical, or in families where there's a lot of criticism, where it may actually be a challenge to have the parent and the child in the room at the same time and working together on this. We do sometimes think about doing parent guidance in lieu of that. Nancy Zucker has written a manual called Off the Cuff. Is anybody familiar with that? At least a couple. So it's an awesome book, and what I'll do is present to you a little bit about her work, and this is a way that we think at MGH too. So the idea is that from infancy, parents' job is to really help kids identify, recognize their needs, and respond to them, figure out how to respond to them. For kids with eating disorders, kids have internalized a sort of demeaning and really critical and unfair or punishing parent that's their eating disorder. And what it has done is interfere with their ability to provide for their basic needs. So they're telling themselves when they feel hungry, you're not hungry, don't eat, you can't eat, no, you don't deserve to do that, or whatever. And in every way that you can imagine, they're ignoring their physical symptoms, or they're not responding to them appropriately. A parent's job is this: when I'm hungry, I need food, there are limits in my life, I need to listen to my feelings to know what I need, and that I can be empowered to achieve my goals. And so a lot of what we do in parent training and in FBT is helping parents re-find their footing. The eating disorder throws everybody off track, and for parents, often what we need to do is just help them kind of get back on track. Nancy's off-the-cuff model. CUFF stands for clear. So the idea here is that in anything that we're asking, we want to be able to communicate clearly and directly what we would like. An example of this is thinking about the family meal, thinking about the family meal and family-based treatment, or thinking about eating in general. When asking a kid to finish, X, Y, or Z, we want to be as clear as possible. I need you to finish your fish. I need you to, continue in that. We wouldn't just say, I need you to clean your room. We might, but actually we wouldn't then be that surprised if what they did was shove all of their clothes and toys under their bed. Not really what we were looking for. We wanted them to hang everything up. And so what we want to do in this C is really be as clear as possible to communicate expectations. The U is really important. Eating disorders are really scary, and they threaten everybody. Parents and therapists can feel really thrown off by them. And what we want to do is do whatever we can to be as calm, confident in what we're doing, to really convey that and communicate that, both to the patient and to the parents. But what we're doing here is working to empower the parents to be calm in these situations. And the idea is that, as you guys can imagine, sometimes, if a child doesn't want to, let's say, have ice cream, instead she'd rather have frozen yogurt, I can imagine that parents would say, okay, at least she's eating, like we want her to be eating. But actually what that does is it really reinforces the eating disorder, because what it is doing is it's saying, I don't want to frighten the eating disorder. I don't want to make the eating disorder upset. And actually that message is the eating disorder is more powerful than all of us. And what we want to do instead of that is to be calm, clear, firm. Health is non-negotiable, actually. You need to have X, Y, or Z to challenge the eating disorder. Firmness conveys appropriate limits and boundaries. A kid with an eating disorder is often really, really struggling with this. And so this is where health becomes non-negotiable in every way. Finally, and for anybody who knows Nancy, you know that she's incredibly funny, has a great sense of humor. Humor really helps us get through everything. So part of that is really recognizing that the eating disorder, or because of the eating disorder, or because of working on treatment, you end up doing a lot of kind of silly things that you never thought that you'd need to do. For example, supervising, a 14-year-old snack. It seems a little silly when you step outside of it. A 14-year-old should know how to do this, but because of the eating disorder, they don't. We cannot trust that they're able to do it. And so it really means re-stepping and figuring this out. This is a bit of a DBT strategy, but the idea that the only way through a wave is to really be able to ride it. When anybody in the room, including kids with eating disorders, are at the peak of their emotional wave, there is just no fighting with that. There's no reasoning with it. There's no having a real conversation about it. Instead, what we want to do is help people come back to the shore where you can have a real conversation. I can imagine anybody in the room who has been at that point of feeling like bubbled over with anger or fear or anything. It's very hard to make logical, rational decisions. And instead, what we would encourage is trying to think about creative ways to use coping strategies to sort of calm yourself down, and at that point, be able to have a conversation. What I usually think about with families I work with is that maybe everybody will just take a quick time out. The kid and the parents, actually. It's sort of an emotional high road, taking a time out to be able to cool off before being able to have a real conversation to problem solve. This one's important, and we've heard actually about this as well today. Parents really provide the first best model for their kids for health and self-care. I'm sure this is not unique to this parent in my group, but one parent that I just revere said, we really need to be able to secure our oxygen mask before helping our child. And I thought, yeah, that's like a genius way of thinking about it. You do. In order to be able to help anybody else, you really need to make sure that you're feeling comfortable yourself. And so we ask our patients and our parents all the time, what do you really want to be modeling for your kid in terms of healthy attitudes, in terms of being mindful? How do you talk about exercise? How do you talk about body image? How do you talk about appearance? How do you think about eating? And how are you eating together? Often, many of our kids will say, yeah, but my mom didn't have breakfast, or yeah, but they didn't have that or that. Yeah, there are certainly different expectations based on health and based on age, but at the end of the day, we do want everybody in the family, parents alike, to be taking care of themselves. We also think about this around healthy striving versus perfectionism. Many of the folks in our patient pool are highly perfectionistic, and many of their parents are highly perfectionistic as well. And one of the things that we work on encouraging is balance. It's lovely to be able to try really hard and to feel like you want to do whatever you can, but being mindful that it's actually healthy striving and reasonable goals versus something that's actually not achievable. After which, if you didn't achieve it, you'd really be able to beat yourself up. We want to be mindful about that. Finally, around nurturing independence, I think about this especially when working with parents of college-age students. We certainly want to be able to support growing independence, provided it's able to be healthy. And that includes things like being ready to go to college, being ready to live in the dorms, being ready to drive, to get her license. Is she able to do this in a healthy way? We want her to be able to be independent. That supports everybody in the room's goals, but only if it's able to be in the service of something that's healthy. And this includes things like being able to communicate with the treatment team. So, my frame, and certainly everybody's is a little bit different, but my frame is really that I see parents as a resource. You can imagine that just based on my model. And in that, I love for parents to be able to be involved. I think about that whether I'm working with young adults, whether I'm working with college-age students, or whether I'm working with the younger ones, where I need the parents to be involved. Parents are a good resource, and if they're not currently a good resource, I guess I'd like to be open to the idea that they could be, and that they're somehow involved, likely in the long term, and we'd like for them to learn more, so that even if they're not where we want them to be, bring them in and let's see if we can educate them to get there. I think about things like the last year, readiness for adult responsibilities and privileges, as being natural consequences for kids who are unwell, for kids, let's say, who are unable to meet their weight expectation, or who are purging in a way that makes us unsure that they're going to be stable to drive. A natural consequence of that is then they're not able to drive. And so trying to be thoughtful about that with families is also useful. I'm going to be really brief in the way of a case example because I want to be mindful of the time. I will just say that when thinking about involving families, I do think about it a little bit differently across the developmental spectrum. So for kids for parents of kids who are in college, I am going to involve them in a really different way. One example I wanted to offer is just thinking about a youngish woman who was a senior in college that I worked with just last year. She had a relatively new onset of bulimia. And she did really, really well in short-term cognitive behavioral therapy. It was a pleasure to be working with her, actually. And her family was also a pleasure to work with. But mom was really engaged and really wanted to find out more about how she could be an asset to this kid, in spite of the fact that the kid didn't live at home. And what they were able to coordinate was the idea of doing Skype around meals and around check-ins after meals. And the reason I share it is that I actually think that's a pretty easily translatable example of how parents can be involved even when they're not on site. And I think it worked really well. What they did was a lot of texting that would just be checking in. And it wasn't a family where I was concerned that they were over-involved or over-enmeshed. Instead, it actually really felt like the kind of support that this kid needed, because it reminded her that there were a lot of reasons outside of her eating disorder to strive for wellness. And I think I'll close there.